Okay, for this lecture, we're going to talk about perioperative nursing. So we're going to look at pre-op, intra-op, and post-operative care. Again, OR is kind of a specialty area, but we're going to talk about some of the basics and focus on nursing interventions in all areas of the operative system. Here are your objectives for this lesson and what you should be able to do by the end of this chapter. I did add the objectives for the 3 separate chapters since it looks at pre-op, intra-op, and post-op. So we have 3 separate slides for all the objectives that we should be able to cover. Okay, so we're going to start with the preoperative phase. Now, the preoperative phase begins when the decision for surgery is made after the provider and the patient has talked about it and decided to go ahead and opt for surgery, and the postoperative phase or preoperative phase ends when the patient is actually transferred to the operating room. So we have a couple goals during this time. So the main goal is to make sure that we assess the patient, gather physical and psychosocial data to establish a baseline for the patient, figure out what risks they have, identify any surgical complications, and then prepare them for the surgery. So during this time, we also want to make sure that we emphasize patient safety and make sure that they are informed and ready for that procedure. So one of the biggest things in the preoperative phase is gathering consent for the patient. So we don't only get the patient to give us consent. What we want to make sure is that the patient is giving informed consent. So making sure that the patient has had a discussion with the provider, the surgeon, understand all the risks, they understand the outcome, they've had a chance to talk about that. They've had a chance to ask any questions, and they are fully informed on what's going to be happening with their procedure. Making sure that the patient is alert and oriented, making sure that they are the patient, right? That they're the ones that are making that decision. Making sure that they're alert, they're oriented, they're informed, and that they've not been medicated previously, that it's not being coerced or anything like that. And just making sure that that's ready to go. So it's your job as the nurse to witness that signature and just make sure that they fully understand. If at any time the patient does not understand, they have other questions, they don't feel like they want to have surgery anymore, it's your job as the nurse to provide information to the provider, letting them know that they've decided not to do that or they have additional questions prior to that surgery happening. So along with gathering a good physical assessment, an emotional, psychosocial assessment on your patient, we want to get any history, any surgical history, any lab values that we need to assess, like bleeding, uh, coagulation lab levels, electrolyte lab levels. We want to make sure that they're ready for surgery. We also want to make sure that we do preoperative teaching during this time, what to expect after the procedure, how they're going to take care of themselves, maybe they're going to be discharged, how to, handle the discharge, how to handle their surgeries at home. We want to make sure that they have all of that education previously or before surgery. So let's see what else. Our other physical preparation, making sure that they're NPO during that time. So making sure that they've been nothing to eat or drink previously to the surgery, making sure that maybe they are prepared with their skin. So we want to wipe them down with an antiseptic, clip their hair, do any bowel prep, make sure their belongings are secured and everything, making sure that we've done any type of orders that the provider has ordered for them to be ready to go for surgery. So I'm just going to recap a couple things. So again, main goals during the preoperative phase is to really establish that baseline, make sure that we identify and minimize any risks, make sure we get that informed consent, making sure that they are physically ready to go. So we have our skin prep, we've done that cleaning of the skin, we've clipped off any hair that's necessary to be shaved or cut off, making sure that we've done any bowel prep. So if it's any type of GI surgery, they'll want to have them completely empty their bowels, making sure they urinate, making sure they're nothing to eat or drink for safety with anesthesia, making sure we administer any pre-operative medications like antibiotics that might need to be given prophylactically prior to surgery. Making sure we educate the patient on what to expect before surgery, kind of during, explain what the OR looks like, who's going to be in their surgery, kind of what's going to happen, and then explain or educate that post-operative or post-surgery um, care that they might need. Okay, so again, here's the little preoperative checklist, things that are usually done in the pre-op area. Usually we definitely want to make sure that we verify the patient, it's the correct patient. We've looked at any allergies the patient may have, especially related to latex or medications that might be used during surgery. We want to make sure that we mark the surgical site. So if they're having surgery on their left leg, we want to mark that so that everybody's aware of where they're having surgery. We want to have the patient informed during that, so making sure the patient agrees to where you're marking for surgery. We want to confirm any labs, vital signs, and diagnostics, so making sure all imaging has been done, labs are within normal limits, making sure, potassium is appropriate, electrolytes are imbalanced or within normal limits. Making sure that we look at coagulation labs, so it's really important to make sure that they're lab levels are normal for, PT, INR, your platelet levels, making sure hemoglobin's within normal limits. This is because during surgery, patients can lose some blood. So we want to make sure that those are within normal limits so we have a little bit of cushion for surgery. We also want to make sure to do our patient belongings list, right? Making sure that they remove any jewelry, take out dentures, remove glasses, make sure they have no contacts in. We remove nail polish, artificial nails, anything like that so that they can get a good oxygen reading. And make sure to document all of that, send all of that personal stuff home with the patient's family, really, or secure it with security if necessary, because this is when a lot of patients' belongings can be lost. For those assistive devices like glasses, canes, walkers, anything like that, those will stay with the patient so that when they come out of surgery and they come out into that post-operative area, that they have these accessible. You want to make sure to verify orders for medications, especially any anticoagulants or blood thinners. Those medications should be held prior to surgery. Obviously, we don't want to, cut somebody open if they've had recent use of anticoagulants. So anything like that, oftentimes beta blockers, heart medications, ACE inhibitors, those types of things, they will still give those medications depending on the provider's requirement for blood pressure and heart rate, but always follow provider's orders for those. So just make sure if you're in, questioning, do I hold this, do I give it, make sure to check with the provider so that we don't give a medication that they may have to delay surgery for if they didn't want them to have it. And then we're going to go ahead and encourage them to have a bowel movement, encourage them to void, so that, they're not having to urinate throughout the surgery. Sometimes they will insert an indwelling catheter for surgery, but always encourage the patient to void prior to surgery. And then this is a really good time to educate the patient on, coughing, turning, deep breathing, and use of incentive spirometer to prevent those risk factors that we talked about for pneumonia and atelectasis in our respiratory lecture. Okay, now we're going to talk about the intraoperative phase. So this is the phase where the patient is actually in the surgical operating room. So this phase begins when the patient enters the OR and ends when the patient is transferred to the PACU or post-anesthesia care unit. During this time, the patient and nursing team work to ensure that patient safety is followed. We really focus on sterility of the surgical environment, physiological stability, so making sure the patient is, hemodynamically stable, respiratory stable, and making sure that we have accurate surgical performance. So we want to make sure that we maintain an aseptic environment, oftentimes in ensuring that sterility is followed. So you'll see that if you ever get to watch a surgery. That center area where the patient is the most sterile environment. We have to make sure that we follow complete sterility techniques, sterile techniques, and making sure that we focus on safe environment as well. We also want to make sure that we ensure accurate identification, especially regarding that the correct surgical procedure site, making sure we're doing surgery on the correct area, the correct side of the body, and that sort of thing. We also want to make sure that we provide psychosocial and physical support for the patient, especially since they're not able to, really move on their own. They're not able to tell us if, something's hurting, if something's going wrong. So we really want to look at their, hemodynamically stable, making sure they're not bleeding, making sure respiratory is intact, really just following the ABCs of that patient. We also want to make sure that we're looking at, their positioning. We want to make sure that we look at, really how they feel, how they, what kind of like anxiety or fear or pain or anything right before they go under any type of sedation. Some individuals in the OR might be, awake when they're having their surgical procedures. So, for example, a patient who's having a C-section for birth, that mom's going to be awake, and so they're going to be able to hear everything and see everything, and so they might be able to verbalize those feelings. Some patients might be put completely under, and so right before they're put under that sedation, they might have a really heightened anxiety or fear. So we really have to pay attention to not just the physical, but the mental part of being in the OR as well. And then we want to prevent injury. We want to make sure that we're preventing infection and any complications. So we're looking at how pressure injuries can occur. We're looking and monitoring for hemorrhaging, making sure that we prevent that as well. And then preventing malignant hypothermia, which is something that can occur with a patient in the operating room. And we're going to talk about that in a little bit. So when we look at who's in the surgical room or in the OR, there's a couple different individuals that are going to be in that surgical suite. So first we have the surgeon or the provider that's performing that surgical procedure. We might have a couple different providers, maybe there's a surgeon, maybe there's a surgical resident. So we might have a couple different individuals there, depending on the level of hospital it is. If it's a teaching hospital, you'll see a bunch of doctors in there. We then also have an anesthesiologist or a CRNA. These individuals are involved with the anesthesia. So their main goal is to provide that anesthesia and then monitor the patient throughout. So they're really focusing on their vital signs, they're focusing on oxygenation, and then they're making sure that their level of consciousness and those sedation levels are appropriate for what they're administering. Then we'll have a scrub nurse or a surgical technologist. This individual is mainly responsible for maintaining a sterile field. They're the ones that would hand the surgeon their instruments. They would be the ones responsible for counting supplies afterwards, making sure nothing got stuck in the patient. Then on the outside ring, we have the circulating nurse. So this is an RN that's usually in the operating room. They're kind of on the outside ring because they're not scrubbed in sterile, so they stay kind of far out in that zoning of the room. They're the ones that are able to coordinate care, kind of manage the environment. They're really responsible with documenting, so that's mainly their goal there is to really document every single thing for a good, accurate documentation. And then they're the ones that verify safety checks. Because they're not sterile, they are able to run and grab extra supplies to pass that in through the sterile barrier. And they would do that, using sterile technique after, but they're the ones that can go in and out of the operating room as needed. But you'll see them usually the OR nurse is the one that's documenting, so you'll see them over on the corner kind of typing on the computer usually. And then we have a RNFA, so that's a registered nurse first assist. And sometimes you might have that in the operating room where it's a registered nurse who also helps and assists the surgeon. So they may assist the surgeon with different types of tasks like suturing, closing up, using the cautery tool, retraction to open something up. So they obviously are within that surgical sterility zone there. When we look at anesthesia types that are used inside of the operating room, you have a couple different types of anesthesia. We have general anesthesia. This is where the patient has a loss of consciousness, loss of sensation, and loss of reflexes. So these patients are usually intubated. They're given this medication, usually the general anesthesia through IV. They could be given it through an inhaled gas as well. So this completely knocks them out, causes them to lose full consciousness, and they're basically fully under anesthesia. Then we have what's called a regional anesthesia. This is usually where they will block certain sections. So the patient is still fully awake. They don't lose consciousness, but they don't have that sensation or those feelings or reflexes. So they don't really feel any pain. So an example of this is like a spinal or an epidural regional block. This is, for example, people with that C-section that I was talking about. They'll be fully numb, no feeling whatsoever from about the waist down. Okay, but they still are able to breathe on their own. They're able to talk and kind of, interact with the surgical staff. Then we have what's called a local anesthesia. So this is just a small area. Usually injection, the anesthesia is usually given via injection, like a subcutaneous injection or topical application. This is usually appropriate for minor procedures or suturing. So maybe, a kid came in and split their chin open. They may do a little local lidocaine to help with the provider being able to suture or put, suture that wound back together. And then we have conscious or moderate sedation. So this is where the patient's able to breathe on their own. They're able to be verbal to stimulus, but they do have a little bit of a decrease in their LOC. So we call this twilight sedation. This is where they're awake, they're talking, they're breathing on their own, but they are so out of it, they don't even know what's going on. This is especially helpful for like cardiac cath procedures or some endoscopy procedures where we want the patient to still be talking so that we know they're breathing, they're circulating, they're fine with their ABCs, but that they don't remember anything going on. And so they're real calm and they're not too anxious. So that's the type of anesthesia that we look at or that we have usually in the operating room. Now, when we're looking at some of the risks and complications, we look at things like hypothermia. So sometimes in the operating room, due to changes in the body and the interaction of the nervous system, we can have patients who become too cold. And so we want to really make sure that we're addressing that complication as well. So for that, we might give them warm blankets. We might give them some warm saline via the IV. Maybe the fluids are warmed, blood if we have to give blood back to the patient, then we would be able to warm that blood as well. Latex allergies. So obviously that's really important to know in that preoperative phase is if the patient has any latex allergies, and we want to make sure that the provider and everybody understands that that patient has a latex allergy. Most equipment nowadays is made without latex, but honestly, there's so many things out there still that do have latex in there that we need to really be aware of that. So that is definitely a risk factor and something to be aware of in the operating room. Then positioning injury. So a positioning injury, like I said, when they do surgery on patients, they need to focus on being able to reach a certain organ or a certain area of the body. So they will position them in a way that allows them to reach it and allows them to work on it. But sometimes this isn't really in proper alignment. So that's why some patients after surgery can be kind of more sore, especially in their head and neck area, their spinal area or their back. That's because of how that surgical table is. They have to kind of prop up their head and have it in a certain position. Other surgeries, depending on what it is, can cause more positioning injuries, like ortho surgeries. Those are pretty rough on the body because working on those bones, they use like full-on power tools sometimes on the bones. So positioning injury can definitely occur. Now we're going to talk about malignant hyperthermia. So malignant hyperthermia is actually a life-threatening genetic disorder. It's oftentimes rare, but it does occur. And if somebody has had it before, if they have a history of it, then they're at higher risk for happening again as well. But this is a genetic disorder that causes a hypermetabolic reaction of the skeletal muscles when patients are exposed to certain anesthetic agents. So this results in kind of a rapid, uncontrolled increase in intracellular calcium. And so it causes this extreme muscle rigidity. It causes hyperthermia to occur. It causes acidosis in the body, which we know is, a bad situation or a, acidotic environment that our body doesn't like, and can lead to organ failure if not treated. So the reason this happens is those anesthetic gases um, kind of trigger the depolarizing muscle relaxants to cause an abnormal release of calcium. Okay, so this calcium rushes out of the skeletal muscle and can actually cause sustained muscle contraction, which leads to increased metabolism. And then that increased metabolism, our metabolism's going crazy like a hyperactive toddler, and that leads to massive heat production. So that massive heat production and increased metabolism causes the body to start rapidly consuming oxygen and leads to a higher level of CO2. So that CO2 builds up, and again, it leads to that acidotic state in the blood, and then can also lead to hyperkalemia due to the breakdown of that, the buildup of CO2 and the breakdown there. So again, this is an inherited trait. So most people will know, they have a family history of it, but you definitely want to gather that information in that pre-op area and then notify the anesthesiologist and the provider that this patient does have a history or a family history of malignant hyperthermia. So what you'll see early signs for malignant hyperthermia, this is going to be an unexpected rise in the CO2 of the patient, even if we're ventilating them more. So if they're breathing more, they're still going to get that buildup of CO2, which is going to lead to that acidotic state. We're going to see tachycardia and tachypnea, so everything's going to kind of increase, right? Our metabolism is kicking it up a notch. And then they're going to start having that muscle rigidity. We'll see this a lot in the jaw, so they'll start to kind of have a clamping down of their jaw. Their skin might be flushed or mottled, so we might have changes in the color. And then we're going to notice that they're going to have some changes in their temperature. So rapid change in body temperature is going to be a late sign of this. So we really want to catch the tachypnea, tachycardia, and the buildup of CO2. We want to catch that early. So making sure that we do that assessing of their vital signs. Um, they also will have changes in their urine due to muscle breakdown that occurs in this situation as well. So they're going to have dark colored urine. So if you have a Foley or an indwelling catheter, you're going to see that dark color urine come as well. So nursing management or priorities for this are going to be stopping the triggers. So first, we're going to stop all anesthetics and medications that are causing this. And then we're going to activate the emergency protocol for it. So we're going to administer some medications. You guys are going to go into this in complex care, so I'm not going to go too far into it. I'm not going to test heavily on malignant hypothermia because it is important for you to kind of understand the in-depth working of it in complex. But you're going to give some dantrolene medication. This helps reduce that calcium release from muscle cells and helps to relax those muscles. And then we're going to do some supportive measures. We're going to give 100% oxygen to decrease that CO2 level, bring that acidic environment down. We're going to cool that patient off because remember their metabolism's working in hyperspeed and they're getting super hot. So we're going to cool them down with some cool IV saline. We're going to put some some ice packs into their groin area, and under their arms. And we may either we may even add some cool or cold fluids into their body through their bladder, their rectum, or through their stomach. And then we're going to treat that acidosis. So remember, metabolic acidosis is treated with some bicarb. So we're going to give them some IV bicarb. And then we're going to treat any hyperkalemia through the use of calcium gluconate or insulin to drive that potassium level into the cells. Obviously, we're going to monitor urine output. We're going to monitor their cardiac rhythm, and we're going to make sure that they don't have any excess buildup of fluids. Okay. So again, that's just malignant hypothermia. You'll go through it in complex care, but just be aware of the rest of the phases or the important things in intraoperative inside the OR. Okay, so now we're going to talk about the postoperative phase. So the postoperative phase begins when the patient arrives in the post-anesthesia care unit. This is called PACU, or that recovery area, and will continue until the patient has fully recovered from surgery. So either they are transferred up to the unit, or they're going to maybe they're going to ICU or med-surg, or they're discharged home. During this phase, the nurse's main focus is for monitoring for complications, doing very good assessments, frequent assessments, making sure that we restore their physiological stability. So making sure our ABCs are intact, but then we also focus on Ds, the rest of it. We want to make sure that their social stuff is intact as well. So we're, making sure that they are able to look at incisions, take care of themselves. If we've removed a limb or something like that, we're looking at anxiety, pain, their feelings, and we're promoting healing of their wounds. Our main goals in this phase is ensuring safe recovery from anesthesia. So we want to make sure that, if they're vomiting, nauseous, if they have any pain, if they have any impact to their respiratory system, maybe they have decreased respirations or decreased oxygen, we really want to assess that and give supplemental care for that. We want to monitor for complications, so paying attention to our respiratory system, cardiovascular system, looking at that surgical site, making sure there's no bleeding, there's no opening of that wound, anything like that. We're looking at signs and symptoms of infection, but that usually doesn't occur for about 48 to 72 hours after. So we really want to make sure that we're just looking at keeping that site clean so that we're preventing infection. We also want to make sure that we promote comfort and pain control, so doing a frequent assessment of their pain, giving them pain medication. And again, we talked about in our pain lecture that we want to medicate before the pain starts so that we can control it, keep them on an even keel for it. During this time, this is where we will do early ambulation. Remember, we want to prevent atelectasis and pneumonia in our respiratory system. So getting them up and walking and moving as soon as possible is one of our goals for post-op. Making sure we introduce nutrition now. We want to start them slowly. So usually what you'll see is they start off nothing to eat or drink because they're waking up. We don't want them to risk choking or aspirating. So until they're able to follow commands and they're really awake and alert and oriented, then we don't feed them or give them anything to eat or drink. Once they're alert, they're oriented, and we've assessed their gag reflex that's returned, then we can go ahead and feed them. And so usually they'll start them on a clear liquid diet and they're going to advance as tolerated just to make sure that they're not throwing up, they're not nauseous, that body after the anesthesia is able to kick back into gear and tolerate food and drinks. And then we want to make sure that we focus on reestablishing that elimination. So most patients will not have a bowel movement for a day or two after anesthesia because that anesthesia slows our gut motility down. So that may be a little sluggish. They may be a little constipated after, especially with use of pain medications. But you want to make sure that they are urinating, especially if they're given a lot of IV fluids in the operating room. They should be able to urinate. They may have a Foley in once you remove that indwelling catheter. They may, retain fluid. So if you don't notice that they're urinating, do a bladder scanner, see if they need a Foley put in or see if they can void. And then this is where we again reteach or re-educate on home care or how to take care of themselves as well. Usually with the post-operative care, they are in that PACU phase. Phase 1 is the PACU, like immediately after surgery. They're usually there for about 1 to 2 hours, just to make sure that we're assessing, the ABCs, their vital signs, making sure they're coming out of anesthesia, and we're monitoring for any emergent bleeding out of that surgical site. Could be a little bit longer if they have any complications or it was a longer procedure, but usually it's about 1 to 2 hours. After that, they're usually sent either home if it's an outpatient ambulatory surgery, or they are sent to another unit. So maybe they need to go to the ICU if they just had open heart surgery. Maybe they go to a tele floor if it was, maybe a knee surgery or something like that, a little bit, not as huge. But during that phase, when we're kind of stepping down or transitioning, we're really looking at pain management, making sure their pain is controlled, starting fluids or maintaining fluids, whether it's IV or oral, making sure that they can void, making sure we follow up on discharge planning and discharge teaching. Okay. So in the postoperative phase, our nursing priority assessments are ABCs, right? Making sure their airway is good, they have a patent airway, they're breathing enough, right? So enough respirations to adequately ventilate, making sure the rate and depth and their oxygen saturation is appropriate. We want to watch for any hypoxia or aspirations. This can occur on their own spit, right? Or maybe they start vomiting and they aspirate. So making sure we're looking at anything they could aspirate on, not just eating and drinking. We also need to be aware of laryngospasms where their airway can actually close up. Sometimes this occurs from different anesthesia types. Sometimes it can occur from surgeries. If they're having surgery on their throat or their neck, that can occur as well. We always want to keep them in a good, safe position. So head of the bed up at least 30 degrees or in a side lateral position to prevent that aspiration. And then also making sure that we're giving oxygen as ordered, okay, as a supplemental way. Once the patient's alert, they're oriented, they're able to follow commands, they're coming out of that, we may be able to titrate that oxygen down and get rid of it. Prior to eating or drinking, we need to check their gag reflex to make sure they have a gag reflex and making sure that they're swallowing appropriately. We want to pay attention to circulation, so we're always assessing for bleeding. We always want to check that dressing. Now, for a post-surgery dressing, the nurse usually is not the one that does the first dressing change. So what we're looking at is we're just looking at the dressing. We're looking for any bleeding that's soaking through, any shadowing, and we may need to reinforce that dressing. But you always want to call the surgeon first if you think you need to take the dressing off or change it, because they oftentimes do not want you to take that dressing off or change it. They want you to just reinforce, hold some pressure, provide supportive measures, and then call the provider. So we also want to monitor circulation. So we're going to do capillary refill, skin color, pulses, especially if there's surgery on a limb. We want to do the most distal pulse. We want to monitor for any tachycardia or hypotension, which could indicate maybe some internal bleeding that maybe we can't see, or problems with the anesthesia, patient coming off anesthesia. If the patient has any restlessness, this is usually that first sign of oxygen being hypoxic, right? So monitor for restlessness. Make sure the patient is coming out of that anesthesia, they're alert, they're oriented, they're able to follow commands. And then we want to make sure to assess neurological, so assess their level of consciousness. They're obviously going to be pretty drowsy, but you should be able to stimulate them, arouse them. They should be able to wake up, answer a couple questions, and you're monitoring that level of consciousness. Making sure that they can move extremities, making sure they have grips and pushes and pulls and things like that, just to make sure that they didn't have any neurological damage from anything that happened in the OR. And then reorient them frequently, make sure they're safe. So safety is a big one for post-op. We also want to make sure that we regulate their temperature. So again, making sure that they don't shiver too much. That can increase the oxygen demand and increase their temperature. So usually they're slightly hypothermic, right? Because that anesthesia causes them to be a little bit colder and the operating room's a little bit colder. So they oftentimes will like warm blankets or a bear hugger, which is kind of that warm water blanket that they use in the OR. Paying attention to the rest of it. So that's going to be pain and discomfort, making sure you administer pain medications as ordered, oftentimes prior to them needing it. So just making sure you have good pain coverage. You also can use non-pharmacological methods like ice or heat or splinting, deep breathing, and repositioning. So pay attention to that pain control. Monitor that surgical site, keeping it clean, okay, so that we don't have any infection or anything like that. Oftentimes you won't see signs of infection until later, but you're going to look for things like drainage, redness, swelling, or separation of that surgical site. That's called dehiscence. That's where that surgical site can just open right up. Anytime your patient has a surgical dehiscence, there's going to be some emergency things that you want to do with it, and we'll talk about that a little bit later. We want to always maintain aseptic technique if you have to do any dressing changes or manipulations. If they have any drainages, any drains like a JP drain or a hemovac drain, you want to note the amount of that drainage, what the color is, what it looks like, to make sure that that drainage should initially out of surgery, it might be a little bit of drainage, but we don't want it to increase. You never want your drainage to be, copious amounts of bright red blood and be increasing. That means there's a bleed. That means something's going on. You want it to be, maybe a little bit of blood in there and then start to change color, get a little bit lighter, go to that serous sanguinis and into the serous, and then decrease in the amount. That means that, your body's getting back to functioning. We talked about the gag reflex. So again, making sure that they have that gag reflex, making sure bowel sounds are present, assessing for any nausea, vomiting, change diet to clear liquid to, as tolerated. So introduce foods and fluids, encourage early ambulation to help get the gut motility going again, monitor urinary output, making sure they're urinating and all that, and then providing that reassurance and support for the patient and the family, especially, any anxieties or things like that. For your discharge teaching, again, we want to support them. We usually start discharge teaching in pre-op, but we kind of want to educate them multiple times throughout the whole experience, mainly focusing on the important stuff. So we want to educate on their wound care, making sure they know signs of infection, especially if they're leaving the facility, so that they can monitor if they get an infection in the surgical site, educating them on pain medication, how to take that pain medication, how to use it safely, how to reduce their risk for constipation or problems with their GI tract, making sure that they understand, lifting restrictions, driving restrictions, any activity restrictions that they'll have. They really need to understand that, especially, if they go and lift an object that's 50 pounds, they could bust open their surgical site and then they got a problem. So making sure that they really understand restrictions that are in place. Encourage early ambulation. So usually all surgeries, mostly patients will get up and walk. Unless it's like a limb surgery, obviously, if they have surgery on their leg, they may kind of be bed rest initially. But even our open heart patients, they have open heart surgery and they're up and walking, later that day. So we really get them up and get them ambulating early, making sure we focus on hydration, good nutrition, and things like that. And then we will follow up, review follow up information. When are they going to follow up with their cardiac doctor? When do they follow up with their surgeon to get staples removed or sutures removed? When to seek emergency care and things like that, especially if they're being discharged. Okay, so now I just added a couple questions. So go through these, read the rationale, see if you answered them correctly, and just kind of revisit the topics that we talked about.